we'll be starting off with labour, birth and obstetric emergencies. These slides have been uploaded into the pre-slides and a lot of it has a lot of information, so we'll just go through the salient points and try to keep it quite short before the next lecture arrives. So these are the topics in your sorry, these are the topics as according to your matrix. We'll try and go through most of it. So we'll start off with labour and birth. Normal labour is divided into 3 stages. Term is at 37 weeks, as you guys know. The first stage is further divided into 3 phases. So you've got latent, active and transition. The latent phase is marked by cervical effacement and dilatation up to 4 centimetres and painful contractions that are not regular yet. The active stage is then classified by cervical dilatation from 4 centimetres to 10 centimetres, and you get established contractions that are more regular. Sorry, I was running here, so I'm pretty out of breath. So in nullity, you expect the dilatation to occur 1 centimetre an hour, and in multis, you expect it to be 1.5 centimetres an hour. And then the transition phase is just a stage that marks the end of the first stage to the start of the second stage, and these are just behavioural behavioural changes that happen. So mum might feel loss of control and overwhelmed, and you just need to reassure them at this stage. So on the right, I've just put assessments that are done during this time, and it's just important for you to know. The next thing is passive descent. So this is just the finding of full dilatation of the cervix and before active pushing actually happens, where there's an active maternal effort to push and deliver the baby, and mum will often tell you that she feels a strong urge to push. The third stage is from the delivery of the baby until the delivery of the placenta. There are 2 different ways to manage it, either physiological management, which is we just let things happen naturally as they would, or active management. So you give them IM, oxytocin, you clamp the cord, do controlled cord traction while guarding the uterus, and then delivery of the placenta. This is just to prevent PPH from occurring. In terms of assessing the progress of labour, we can divide it into the 3 Ps. So the pasture, which is the baby, the passage, which is the uterine passage, the passage of the birth canal, and the power, which are the contractions. These are just some terminologies that you guys should know. I'll just skip through them. And then I just put this in there to know for EMQs, it's possible for you guys to need to know the process of the presenting part as it progresses through the birth canal. In terms of the passenger, to assess it, you can either do fetal heart rate auscultation, which you do in fetal heart rate auscultation, which you do in women who don't have any complications, or you do continuous CTG, which is cardiotocography, in women who have risk factors that have either been identified in pregnancy, at the start of labour, or during labour. It's very reasonable for you guys to get a CTG that you might need to interpret in an OSCE. So the acronym to use is Dr. C. Bravado. First is to determine the risk. Why were you called to review this CTG in the first place? Then you look at the contractions, where you look at the frequency and the duration of them. On a CTG, the strength isn't demonstrated really well, and that's more through abdominal palpation. Next thing you do is baseline rate, then accelerations, which is the fetal response to stimulation, and variability, which is another good thing that we want. And then D cells. You've got early and variable D cells. Both can be normal, both are normal physiological reactions. Early is due to head compression during contraction, and variable is during cord compression. Variables can be complicated if they're associated with other features on the CTG that are abnormal, so you might need to review them and always look at the rest of the CTG. Prolonged and late show different extents of hypoxia, and sinusoidal shows severe anemia with a HB of usually less than 50. Then you look at the power. This just shows the difference in the contractions between pre-labour, first stage, latent phase, and then the established labour. I just want to highlight that in established labour, you get longer contractions that are 40 to 60 seconds. They're stronger, and the frequency that we usually like to quote is 3 to 5 in 10 minutes. If it's anything more than that, it risks decreased circulation through the baby, through the placenta. Then you look at the cervical changes. You guys would have seen this table before. It's the Bishop's score. So we just look at the dilatation of the cervix, the length, the station of the presenting part, the consistency of the cervix, which goes from firm to soft, and then the position. The partogram, I just chucked that in there for you guys to familiarize yourselves with, because that's also something that you might be asked to interpret. The alert and the action line. both here are rising at a rate of 0.5 centimeters per hour for dilatation, which is again just to show you that there might be to be aware of any delay in labour. So in first stage delayed labour, this is suspected when nullips are progressing at less than a rate of 0.5 centimetre an hour, same for multis, or if they have a slowing down in their progress. If it's diagnosed as delayed, the first thing you do is look at whether the membranes are intact or not. If the membranes are intact, you perform an ARM and then repeat the vaginal examination and assess if they've had progress. If they haven't, then you might need to consider starting an oxytocin infusion. If the membranes are ruptured, so for nullips, you consider augmentation with oxytocin, and for multiparas, you need to consider this with the input of a senior obstetrician before you actually do it, because there are increased risk of uterine hyperstimulation and uterine rupture. And then depending on that, you either commence the oxytocin infusion or you consider a cesarean section. In progress after 1 hour, you suspect it, and it's a diagnosis if there's no birth within total 2 hours of active second stage of labour where there's active maternal effort to push. In multiparas, it's 30 minutes and 1 hour. You add on an hour if they've had an epidural. Management plan, the main difference between them again is the oxytocin. In nullips, you can consider oxytocin, but in multiparas, you're less likely to do it because of the risk of that. Sorry, I'm losing my brain. The uterine hyperstimulation. Prolonged pregnancy is a pregnancy that's gone for more than 42 weeks. You're at increased risk of fetal death in utero at this stage, but this occurs earlier in South Asian women, which is why fetal surveillance for them is commenced at 39 weeks. You do a twice-weekly fetal surveillance, and that's at 39 weeks for South Asian women and 41 for other women. So if you ever get a station that's prolonged pregnancy, make sure you ask their ethnicity because this has come up in the past. Consider membrane sweeping from 40 weeks and induction of labour from 41 to 42 weeks. Induction of labour, you've got different indications of prolonged pregnancy, term rupture, pre-labour rupture of membranes, and concern for fetal well-being. You looked at the Bishop's score, which we saw before, and the magic number is 6. So if it's less than 6, it's unfavourable and you need to do cervical ripening. If it's more than 6, then it's favourable and you can just proceed to induction of labour. Prostaglandins and Foley or the balloon catheter are your two methods of cervical ripening. Monash's preferred method is a balloon catheter because the balloon catheter because it's easy to control, whereas prostaglandins also run the risk of uterine hyperstimulation in combination with induction of labour. So with induction of labour, you can either do ARM or oxytocin infusion. I just put in a link there that shows more information about it. Instrumental delivery you can either do with forceps or ventouse. The main thing I want you guys to take away from this side is the prerequisite, so forceps. So before they have to have an instrumental delivery, they need to meet all of this criteria where they're fully dilated and in a favourable position. The station is 0, so they're fully engaged. The membranes are ruptured, contractions are present. The bladder is empty and you need to consider an episiotomy, especially if they're having a forceps delivery, and give the mum adequate pain relief. This is just a table comparing the two. The thing to take away from this is maternal trauma is more likely with forceps and fetal trauma is more likely with a ventouse. Can anyone tell me what this is? Yes, I heard someone say it. So it's a chignon, which is, chignon, which is, it's just localized soft tissue swelling at the side of where the ventouse cap was. It's safe and it'll usually resolve in a few days. You just need to reassure the mum and the partner. This is just a diagram showing the different types of bleeds that you can have with either forceps or ventouse. You need to know the difference between a subgaleal and a cephalhematoma because you can get them as a picture. Thing about the subgaleal is that because it's bleeding under the scalp, you get this global swelling, versus with a cephalhematoma, it's bleeding within the periosteal layers, so it doesn't cross the suture line. So it's just a unilateral swelling, which is this. So if you get a picture, which we did last year in the EMQ, know how to differentiate between the two. Cesarean section you guys all know about. The main thing to know is to counsel a woman between the differences between a cesarean section and a VBAC. VBAC is vaginal birth after a cesarean section, and just know some numbers. So they have a 60 to 70% success rate, and they've got different factors favouring success and also factors that make them more likely to be unsuccessful. So PROM has really good guidelines of this, and if you guys don't have access, then I can just email you the PDFs. But you just need to know the risks. So cesarean section has the usual surgical risks, procedure-specific, so bowel, bladder, and ureteric damage, and the potential need for a hysterectomy. And post-procedure, if the mother wants to get pregnant again, they have to undergo all of the VBAC risks in that next pregnancy, or they might have placental abnormalities in the future pregnancies as well. Risks for VBAC, uterine rupture, know this, 5 in 1,000, increased risk of perinatal mortality, risk of a need for emergency cesarean section in 25%, which is quite a lot. And important to again reiterate that emergency C-sections are safe, but they're less safer than planned cesarean sections. And you can also have pelvic floor trauma, as with any vaginal birth. This is preterm labor. It looks like a lot, but this is basically just a slide going through how you would approach it. You guys should also know the implications for preterm labor on the baby, the different systems it can affect, and the potential complications. That's what we had as an OSCE station last year. In terms of history, confirm the estimated due date, and you look for signs of labor, so the contractions and the rupture of membranes. Go through an examination and send off some pathology. You check fetal well-being with a CTG, provided it's over 28 weeks and you think the baby is viable. With the spec exam, you do that in a sterile manner, and if there's LICA, you do a high vaginal swab for MCS, looking for any infections. If there is no LICA, only if there is no LICA, you visualize the cervix and perform the 2 tests, fetal fibronectin and amnisure. These aren't ones that you always perform routinely. So fetal fibronectin just kind of indicates when, if the baby is imminent for, will have imminent delivery. So the important thing is that positive result does not necessarily indicate onset of labor, but negative result indicates less than 5% chance of giving birth within 7 days. Amnisure is something that you use to check if they've had a rupture of membranes, and you only do it if you can't see the pooling of the liquid or if you can't see the intact membranes on the spec exam. Very accurate, and it just tells you if there's been ruptured membranes or not. If the membranes are intact, then you can do a vaginal examination to assess the cervix for dilatation, but if the membranes are ruptured, you do not do a vaginal examination because you don't want to introduce infection. This is just the management of a preterm labor. So tocilizis is a method used to kind of delay the birth. It's only really justified ever if you need to do in utero transfer. So if you're in a rural centre and you need to try and get them to a tertiary centre, or if you want to try and do steroid loading. Nifedipine is the agent of choice. With corticosteroids, this is the number that you need to know: betamethasone 11.4 milligrams IM, 2 doses 24 hours apart. And you do that between 24 to 34 weeks, and it plays a role in fetal lung maturation. Antibiotics are used to prevent early onset GBS disease, and they're indicated if it's confirmed preterm labor and if the membranes are ruptured. It's the same as PROM, which I've got there, so I'll show you guys later. And then Magsalf is just for neuroprotection that you give if the gestation is less than 30 weeks and you think mum will give birth in the next day or so. PROM is much the same, but you don't really do fetal fibronectin for them. So PROM is preterm pre-labor rupture of membranes. In terms of management, there's just a few other considerations. Those are the antibiotics that you use. There's different antibiotics that you use for antepartum and intrapartum. And then you just have additional considerations for the timing of birth and the surveillance that you do. For timing of birth, you need to expedite it where you think that there's no reason to justify delaying it. And you can consider expectant management for until 34 to 37 weeks where you don't need to steroid load them anymore. Surveillance, again, you're checking the mum for chorioamnionitis and you need to counsel her on looking for any of those symptoms that you might find. And then you do fetal surveillance as well. Over 28 weeks is a CTG, and under 28 weeks you do a biophysical profile for them. PROM is pre-labor rupture of membranes that happen after 37 weeks, so it happens after term. Assessment is the same as PROM, but management is where it differs. You get expectant management versus active management. In active management, if they are GBS positive or have the risk factors for GBS, or you suspected sepsis or any kind of fetal or maternal compromise, You do induction of labour and intrapartum GBS management with the antibiotics. In expectant management, if they don't have any of the risk factors and if you think they're fine, you monitor them every day until 96 hours where you do the induction of labour, and that's the maximum time frame you have. And then the additional thing is just the GBS intrapartum management again with the antibiotics. This is just a little bit on breech presentation. I put that in there because you guys should, one second. You guys should know about external cephalic versions and how to counsel a woman on whether to do that or not versus a vaginal breech delivery and an elective cesarean section. So breech affects 3 to 4 pregnancies beyond 37 weeks, and there are 3 different types: frank, complete, and footling. Your 3 management options are the vaginal breech delivery and the elective cesarean section. Since the publication of the breech trial, there has been more incidences of elective cesarean sections because it's showed decreased perinatal morbidity and mortality as compared with vaginal breech deliveries. But because you have the additional surgical risks and complications of a cesarean section, ECVs, external cephalic versions, have increased in incidence too to kind of offset that and mitigate both. So ECV is when the fetus is externally rotated from a non-cephalic to cephalic presentation by manipulation over the mother's abdomen. It's offered between 36 weeks and 37 weeks. 36 weeks for nullips versus 37 weeks at term for multiparous, because multiparous women are more likely to go into spontaneous labour with the ECV. That's just the method to do it, but Prompt has all of the methods on how to do it, and you guys should be familiarize yourself with that. Next, we move on to obstetric emergencies, and I think I have some time. Yeah, till 10. Perfect. Okay. So antepartum hemorrhage is bleeding from the genital tract for more than 20 weeks gestation. The causes, you all know the placental abnormalities, but it's important in a real life situation to also know that approximately 45% of these people who present actually come for other lower genital tract bleeding from the cervix, the vagina, or outside. The severity is really hard to quantify the blood loss, so you want to look at the maternal and the fetal clinical condition. These are the list of complications from antepartum hemorrhage. The main thing to understand is that death is both possible for the mum and the baby, so always treat these seriously. And this is just a management pathway, kind of just taken from Prompt and made a little easier to read. So you do the initial assessment. You always, in your auscultation approach, you say you're going to do doctors ABCD, get the vitals, quantify the blood loss. If the mum is, so it's either unstable or stable APH, where you're looking at the mother's hemodynamic stability. If the mum is unstable, so here, you go down and you stabilize the maternal condition. Always call for help, which you would have done up here. IV fluid resus, send investigations, and monitor urine output, because that's one of the early signs of severe APH. If you manage to stabilize her condition, then you ask for more of a history, do more of an examination, determine the placental location with either a previous ultrasound, or you can do the ultrasound there, which you would do anyway, and assess the bleeding by spec. I put plus or minus VE because you don't want to do it straight away in case they've got like a vasa previa or a placenta previa, which it's contraindicated in. And then you send the appropriate investigations. You assess the fetal condition with a CTG, provided that they're over 28 weeks. And then depending on how they go, you're calling like a code green or expediting the birth and considering steroid loading and mag-sulf, or you admit them for observation and never forget the anti-D. In these women, consider birth if they're over 37 weeks because they're already at term. The pathology that you order depends on whether it's a minor or a major hemorrhage. And I guess the main thing to remember is you want to either group and hold or cross-match bloods and start a massive transfusion protocol. Clyhow is required for all rhesus D negative, so in your history and examination or your investigations, always find out what blood group they are. And then your imaging is just your ultrasound. Placenta previa is placental implantation on the lower uterine segment. It's classified into major and minor. I think just the presentation is painless PV bleeding, and they might have had previous cesarean sections. I will keep going. Placenta accreta, increta, purcreta are all morbidly adherent placentas of varying degree. They might have painless PV bleeding as well. The main thing to note in their management is that they might need to have a hysterectomy, depending on what stage they are at in their family planning, whether they want more babies or not. Vasa previa, the main thing to take away from this is it's actually fetal blood loss, not maternal blood loss. It can happen from two ways, either a velamentous umbilical cord or multi-lobed placenta, where you get the blood vessels that are exposed and below the presenting part on top of the os. Even if it's a small bleed, it's still significant risk to the fetus because they have a smaller blood volume. So they can have major implications. So usually if these babies present like this, they'll have fresh vaginal bleeding plus fetal heart rate abnormalities. And then management includes just rapid delivery and aggressive resus for them. Placental abruption is premature separation of the placenta from the uterine wall, just a painful tender abdomen and PV bleeding. I'll keep moving on. Postpartum hemorrhage, blood loss of more than 500 mils during the puerperium, more than 1 liter and it becomes major, and you can further classify it into primary and secondary. Main thing you guys need to know is the 4 T's: tone, tissue, trauma, and thrombin. Tone is the most common cause. These are just some risk factors that are associated with all of the different T's. I won't go into that, but I'll go into prophylactic measures. We're always doing it anyway. So during pregnancy, when we take an antenatal history, if we're asking the woman if she's had a previous pregnancy, did she have PPH in that? We're always checking the HB because we're doing a full blood examination as a part of our initial workup, and we do know the placental location when we do their routine ultrasound in the 2nd trimester. In ladies with a high risk of PPH, more planning goes into their labour. You might want to establish IV access earlier, do a full blood count and a group and hold, and plan for a transfusion or a postpartum oxytocin infusion. Senior obstetricians need to be present for these women, and we always do active management of 3rd stage for them. So we went through that before. And consider a cesarean section, especially if they have placental abnormalities, if you just want to just bypass these risks altogether. This is just the management pathway. I'm not going to go too much into this. I don't think you need to know the, you might actually need to know the dosages. I think it came up in last year's exam. I can't remember. But first, you need to just kind of like split it up into 3 different things that you're managing. You always say in an approach in an OSCE that you would do all of these 3 things together, but you're going to split them up first. First thing is communication. You're going to get a handover from a midwife who tells you that this lady has had blood loss. Ask them how much, what is the gestation of the woman, what kind of condition they're in and what their vitals are. You can get like a brief antenatal history, any past medical history, and you always call for help. You call a relevant code and maybe start the massive transfusion protocol. Always assign roles. You'll be the person who's standing back, coordinating the whole thing. You want to explain to the mother and partner, because the partner's going to be watching the mother, like, losing a whole lot of blood, and they're going to not know what's happening. So always make sure you assign someone to tell the mum what's happening and introduce yourself to them. In terms of controlling the bleeding, you look at the 4 T's. Tone. First thing you do is fundal massage. You give them the uterotonics, which are these, and you empty the bladder because that can also help. Pressure from the bladder can worsen the bleeding. The 4th thing that you might consider surgical. By then you've already called the code green, as in Monash, and theatre would be ready for you. With tissue, you check if the placenta has been delivered. If it's been delivered, you ask someone to see, is the placenta whole? Are there any parts missing? You can attempt a vaginal examination and removal, or you might need to transfer them to theatre for manual removal there. Trauma, you expect the perineum, the vagina, and the cervix for any tears or ongoing bleeding from there, or bleeding from the episiotomy site, and you can apply pressure or suture to repair. And then with thrombin, you do your bloods and your clotting profile and just give them blood products until someone senior comes and can manage the situation for you. In terms of resuscitation, you guys know all of this already, so I won't even bother going through it. But the main thing to tell the OSCE examiner, if you do get this, is to say, I will be doing all of these at once, but I will be splitting these up to categorize them in the different management. Cord prolapse is the next one, which is where the umbilical cord lies in front of or beside the presenting part in the presence of a ruptured membrane. It's associated with a high perinatal mortality. There are different risk factors like high presenting part, high parity, prematurity, multiple pregnancy, and polyhydramnios, things like that. Management is you call the code. You replace the cord above the presenting part, or you try and dislodge the presenting part to stop it from compressing the cord. And then you place the mother in knee to chest position, or exaggerated left lateral. You either immediately get them down to theatre, or if their birth is going to be imminent, then you try for a vaginal birth. Shoulder dystocia occurs when the anterior shoulder of the fetus is impacted behind the pubic symphysis. And then just prevents the delivery of the baby. These are the warning signs you need to know: difficulty in or slow birthing of the face and the chin, turtlenecking where the head is retracting in and out, and failure of the fetal head to restitute or the shoulders to descend. HELPBIRD is the acronym that PROM uses. First thing is call for help. Second is episiotomy. Third is legs in macrobit, so knees to nipples. Then you put suprapubic pressure over the anterior shoulder. So you need to determine which way exactly the baby is lying. And then basically it's just like either a constant or a rocking motion. And then you enter and you do your enter maneuvers. Rubens 2 is when you put 2 fingers on the posterior aspect of the anterior shoulder and push. You add a finger, you add 2 fingers to the anterior aspect of the posterior shoulder and push like this for wood screw, and then you swap them around for reverse wood screw. 30 seconds for each, so you need to have someone timing you. You do not spend any more time doing it than that. If that doesn't work, you try and remove the posterior arm after that. If that doesn't work, you roll onto all 4s and do it again. After this, if that doesn't work, then the baby is at serious risk of hypoxia and even death. And you might consider other maneuvers such as like a clitotomy, where you break the clavicle on purpose and then deliver the arm, or Zavanelli's, which is where you push the baby back into the uterus and then Caesar, and then pubic symphysiotomy. And then document and debrief with the mother and the partner, make sure they're okay. Uterine rupture is a full thickness tear through the myometrium and the serosa. The most common cause of this is rupture of an old Cesarean skull, which is why you guys need to know VBACs. The diagnosis, there are quite a few symptoms. The main ones are they have a sudden severe abdominal pain. They have bleeding, which is either intra-abdominal or vaginal. And they've got a tender abdomen with cessation of the uterine contractions. There's also maternal and fetal compromise. In terms of management, aggressive resus, immediate laparotomy to deliver the baby and repair the uterus. And sometimes, unfortunately, this proceeds to a hysterectomy. And that's all.